So Pam, good to see you. We last did this 10 or 12 years ago when we talked about, we're interviewing you as the 13th ASE president. A lot of things have happened over those 13 years, professionally, personally, and otherwise. But you've done some really innovative things. I think you had mentioned, and it's true, that you're really an imaging clinical trialist. In other words, you've done some phenomenal things with that. Tell me a little bit about how you got interested in that and where it's gone.
Well, first of all, great to be with you here, Randy, and to be recording these things. We're all interested in history and we're interested in the future, and those two are often the same. And so it's important to inform things. I got interested in imaging clinical trials because of imaging quality. And way back in the 90s when Jules Garden was president, ASE president, we had a long discussion about what it was going to take to move the needle on reimbursement for echo. So if we go way, way back, we start with, the business side. But more than that, we said, well, we want to make sure we're delivering a quality product and not just doing a bunch of echoes. Mm-hmm. And so how do we think about quality? How do we start talking about quality? And fast forward 10 years later, we did the appropriate use criteria, and echo was, we did 4 or 5 echo documents, including pediatric document, TEE, transthoracic. Mm-hmm. And then out of some of that experience and thinking about how we quantify cardiology value in imaging, we realized that we were really talking about technical specifications and diagnostic performance, pixel size, temporal resolution, and sensitivity and specificity, but not how it would actually change the care or the outcomes of the patient.
You didn't have clinical data.
Well, we didn't even want to have clinical data. The evidentiary standard was diagnostic accuracy. Right. And so we had an NIH workshop and decided we could actually do this, or at least try doing this in imaging. And then over the decade, from about 2005 to 2015, a number of different studies started that did randomized clinical trials, very standard randomized clinical trial, adjudicated endpoints, monitored follow-up, all this kind of stuff, looking at imaging strategies in a variety of patient settings. And they turned out to be very feasible and to indicate that imaging used properly can actually save lives. And this is revolutionary, right? We never even tried to do that, before about 10 years ago. Now that's the standard. And I think that elevates the whole field of imaging. It's not just about this modality versus that modality, but it says that imaging and imagers need to pay attention to how they're benefiting the patient and not just to doing a good job in their labs.
It's interesting because you're really talking outcomes, clinical outcomes.
Yeah, absolutely.
And we all talk about that, and that's tied to value. Mm-hmm. That's basically value-based care. I mean, if it's affecting, can you give me? I was listening to you, and I'm thinking multiple thoughts. Can you give me an example of one that really stands out to you?
Well, I can. My work has been centered around chest pain evaluation,
right, that's
initial
what I was
chest
thinking.
pain evaluation. And this was the very first large randomized trial in cardiovascular imaging. And what we showed was, in the PROMISE trial, was that CT really wasn't an improvement over functional testing, at least as done then in those settings. And, CT has since improved, but echo and nuclear and everybody has since improved. But I think that there was a little bit of a bandwagon to say that that everybody needs to jump on the new technology. And in fact, we said the old technology is still pretty good. The event rates are low. We pick up a lot of things like myxomas and stuff like this that we hadn't expected before that you might not see. The radiation is zero, which is a nice patient safety advantage. And so I think we learned so much from taking a patient-centered approach to what we do and an evidence-based approach.
Do you think that I'm just thinking of the payers, okay? The payers, and there are multiple payers. Payviders are coming along, all those. Do you think, are they attuned to what you've discovered?
I think they are. I think they get pulled one way or the other, and they have a lot of constraints, and they certainly use financial outcomes as a more important benchmark than we tend to do it because we're not paying the bill, ourselves. But I think they understand the value of a prospective approach to appropriate use, of generating evidence, and of doing a really good job when you do imaging and do echocardiography.
Has quality improved?
I think quality has. Appropriate use is certainly the inappropriate use or the rarely appropriate uses have really decreased. The idea of routine stress testing before cataract surgery or vascular surgery without a reason, I think that's really gone away, and the utilization has gone down, I think, in some. In other cases, and this is particularly true for echo, the real-time bedside nature of echocardiography is just so unique. And we found this in the pandemic when, COVID has cardiac side effects, and with a little handheld, machine at the bedside in an ICU, you can get a lot of information very quickly that is so important to that patient. And that value of echo, really hasn't been codified in a trial. We haven't randomized COVID patients to echoes and no echoes, but it's been proven, I think, in the court of clinical care, if you will, that having that information is so important, and being able to get it at the bedside rather than wheeling a patient down to a scanner is just invaluable.
And you're exactly right, and I think the pandemic propelled to out-of-hospital use of this technology too. I mean, I think that we're just on the infancy of that, which makes you come back to quality. But you were one of the ones that said less is more, and it's true. You don't need 150 clips to be able to put people in silos of disease diagnoses and things. I'll come back to that in a second. You've also been very engaged with looking at multimodality imaging, competitive modalities, if you want to say that. Tell me a little bit about your thoughts on that.
My thoughts on it, there's two thoughts. There's the workforce thought about this aspiration that we have for multimodality imager. It's been maybe 20 years now, at least 15, that people have proposed that, and outside potentially of some private practice settings where people really do need to read echoes on Mondays and nukes on Tuesdays and CTs on Wednesday. The academic thought leader, I think it's extremely hard to do multiple modalities at the level 3, with research, with teaching, that you need to do to be an academic center and to really be a thought leader in the field. I get the level 2, just, do the clinical work in the trenches. But for thought leaders, for lab directors, for educators, I really think that the deep, deep knowledge that we get in 1 or 2 technologies, modalities, is where we need to go. And this is not an ideal. You're never going to have thought leaders in 4 technologies all at the same time. It's impossible. Our brains aren't that big.
Where do you see echo? Okay, let's talk about whether it's point of care or whether it's full bore echo going over the next 5 to 10 years versus, the hot stuff of CT, especially in structural and MR and things like that. Where do you see echo fitting in?
I think echo will fit in the ways that it always has. Again, real time, at the bedside, no radiation, quick diagnosis, relatively inexpensive, so amenable to serial studies. I think it will continue to have those advantages. No other technologies come close to those. Yes, you may get beautiful pictures with an MR or a CT, and you may be able to detect things, with a particular MR. protocols that you can't detect by echo. But echo is there when you need it, right? And no other modalities like that.
You're exactly right. And as I said, those of us who have been doing it our whole lifetime know that give me one or two, three views, and I can, with our brains that have seen.
90% of what's going on.
Absolutely, yeah. At least, absolutely. Which brings me to just the topic that we've been talking to a couple people and recently, and they're all past presidents. Mm-hmm. They're all mentioning artificial intelligence as playing a role in some of that. Your thoughts, where that's going, and it's not in reference to me or what I'm doing. No, but just your thoughts in general. Where do you think that's going?
I think it's in its infancy. Mm-hmm. I think it's incredibly promising. It'll be useful for acquisition, which is the end that you're involved in. It'll be useful for analysis, but it's not going to replace people. And in the radiology world, where it's more advanced perhaps than it is in the echo world, it serves as a safety net and a triage function. And so it says, look here, or consider this diagnosis, as opposed to, let me write the report and you just sign it. So I think that's where it's going to go, at least for a while. It's not going to replace a talented physician with a sense of the patient and the arc of the patient's disease.
Fabulous. Pam, you've been really an innovator and done a lot of things with the college on diversity, inclusion, respect, things. And we were talking before we started this about the changes that we've seen in our societies. But tell me a little bit about your interest in that and what your thoughts are.
Well, I've had a lifelong interest in that, being a woman in cardiology, and a relative rarity. I think when I graduated from fellowship, it was somewhere around 2 or 3% women, and so there was always that little bit of uphill climb and feeling like an outsider, which peaked when I realized that the pipeline was now full and nothing was changing at the very top. Mm-hmm. And so for a long time I thought, well, we need to get the pipeline, we need to skill women and teach them how to negotiate or whatever. And then I realized the pipeline is full, nothing's happening. Women are getting more skilled, nothing's happening because the playing field isn't level. And it doesn't matter how much you upskill somebody, if you still let them on an unlevel playing field, they're still going to be at a disadvantage. And so I said, we really need to change this. And it's about the culture. It's not just about my advancement or somebody else's advancement. It's about the culture. And so let's look at why we need to change this, not just social justice for me and others like me or people of color, but why does the field need this? And really worked around a business case about making better decisions, having diverse leadership, financial benefits that have long been shown in business. So that's one. Two is access to talent. If half of the women in internal medicine residency programs won't consider cardiology because they think it's not family friendly and not a good place to be, which is the truth.
That's the truth. Yeah.
We're losing a lot of talent, right? And no enterprise can lose 20 or 30% of its talent pool and not suffer. So talent is one. And the people that come into cardiology need to have the option to improve if they want to advance. And the final one is patients. Patients need diverse providers because they need people to understand diverse needs, whether it's cultural or religious or language or whatever it is. And the data are very good that patients of color are more likely to keep appointments when providers are of color, more likely to be compliant, more likely to tell the physician or the caregiver things that they wouldn't tell a different race, ethnicity. And so for the sake of the patient, we need to do it too. And as we learned so much about health equity in the pandemic, or about health inequity
yeah.
in the pandemic, it's really become clear that diversity amongst clinicians is part of the solution to that. And so those three reasons were very powerful to people who didn't necessarily feel like there was a problem but open their eyes to it. And through innumerable little changes through the fabric of the college, making sure every committee and every chapter reported on diversity efforts, doing health policy statements that represent ACC policy, changing code of conducts. The college has become a very different place. For the last 2 years, every single podium at the annual meeting has been diverse for the last 2 years. Tremendous change. The proportion of women going into committee slots is now close to 40%. It's very different. And part of it, I mean, I'm certainly not going to take the credit for it by any means. A lot of people got the same idea at the same time. And nationally, the conversation around first Me Too and then Black Lives Matter elevated that boat. And I think we've seen this in ACC as well. I mean, ASE as well as ACC. But we need to do more.
Yeah, I mean,
we need to do more.
No, you're very articulate, but I think that you've been the ACC, and you've been a key at getting that going, and is maturing along. It's not there yet, but I think the ASE needs to, and the ECHO world needs to jump in, right?
I think we do. I think and some of the diversity issues are, potentially a little bit different, where we've got a sonographer workforce that's mostly female as opposed to minimally female. But we still often have men rising to be lab directors and so on, disproportionately. Same with pediatric cardiology. It doesn't reflect the workforce, so it means that opportunities are limited for kind of the rank and file. ECHO has been a wonderful haven for many women in cardiology, and imaging is probably the most diverse in terms of representation of women of all the specialties within cardiology, but I think we can still do better.
Is that because of the lifestyle that's associated with that versus being an interventional? Or I'm thinking about, we were having a conversation earlier, not recently, about women in surgical professions, especially thoracic surgery or cardiac surgery. But do you think that women with decreased opportunities to advance migrated to non-invasive imaging because it was a safe haven?
Now, see, those are two different things, and it's really interesting. So decreased opportunities to advance is a very different setup than I don't want to take STEMI call.
Correct.
Very, very different. And when you talk to women, they say, I was discouraged, I was discounted, I didn't have the opportunities that others did. I had very subtle benevolent sexism is the term. Like, are you sure you want to do that? It's hard to have a family and be an interventionalist. As opposed to, you are really talented in the cath lab. Let's figure out how we can make it happen for you. Those are the things that deter women, and not, oh, I don't want to take the call. I don't want the radiation. Men think it's the call and the radiation. Women know it's the opportunity and the mentorship. And so that dichotomy, I think, is one that we really need to drill down at. Because I think men are well-meaning when they say, do that benevolent sexism stuff. But they're also reluctant to change their narrative about, I am, the worst call night is the best call night, right? The strongest cardiologist is the one who survived, something, and go big or go home. And I think we need to change. Surgery has attracted women because it has changed as a profession. It has thought deeply, deeply about not just diversity, but about work-life balance for men and women. And it's OBGYN. Here's another example. 75-80% women. Night call, operating room, it's tough, but it's shift work, right? So if no woman expects to get delivered by their primary gynecologist or primary obstetrician, right? They expect to be delivered by the team. And so, if you're on call all night delivering babies, you go home and get rest. And quite frankly, nobody wants you to be delivering babies the night after you've been up all night. But in cardiology, you've been up all night in the cath lab. You do all day in the cath lab, or in thoughtful practices, you do all day in the clinic. But but quite frankly, I don't want to be on the other end of a sharp instrument of somebody who's just been up for 36 hours.
Yeah, no, that was the reason I asked that. Let me just, in conclusion, what does the ASE need to do, or the ECHO world need to do to accelerate the diversity and inclusion and respect?
I think, well, there's a number of things. Awareness is the first one. Awareness and leadership. And it needs to be top down. This is not something that's going to bubble up from the grassroots, because it is culture change. And so all the, John Goddard steps to culture change apply here. You need to have a vision, and you need to instrumentalize that vision, find supporters, find allies, and make it happen. And we need to do it throughout the organization. We need to do it in our annual meeting by setting targets, in our committee positions by, again, setting targets. And we need to make it very clear that this is good for the organization. This is not about social justice, although that's a pretty nice side effect. But this is about what echocardiography needs to do to be stronger. And it's an easy case to make if you take that angle. And then it becomes obvious, well, this is when we need to do stronger, then we should do it all the time. We should not make business decisions that don't have a diversity consideration. For example, the board. Mm-hmm. Every consideration, every decision needs to say, well, how does this interface with health equity and workforce diversity and inclusion?
Well, I could listen to you forever, but I'm not sure. I'm not sure, even though you're fascinating, I'm not sure people want to either hear me or listen forever. You've had a phenomenal career, and have changed the care of medicine, the care that people have gotten, and changed our field. So I'm appreciative of that, and I'm hopeful that you'll stay as forceful as you've been and as contributing as you've been for quite a while.
Thank you so much. It's really been an honor and a privilege to do everything that I've done. That's nice.
It feels better for you.